can see all obstacles in my way. Gone are the dark clouds.
When we're troubled, stressed, or worse, chronically ill, one of the great uplifting moments is that spark of empathy, of true understanding that comes from another. The supportive word of a family member, a friend, or a healthcare provider can draw us up from the darkness of worry and of anxiety. Empathy is more than a supportive shoulder, though. It's the expression that someone understands and truly cares about our troubled journey. Good morning. I'm David Woodlock, head of one of New York City's largest not-for-profit human service agencies, ICL, the Institute for Community Living. We're a mental health, family support, residential assistance, and treatment center helping some 10,000 people each year. In my more than 40 years in the field, one of the great paradoxes of our time has emerged. Our inattention to the emotional dimensions of health and illness is a public health perfect storm, especially for the mentally ill. Those individuals experience high rates of illness, suffer greatly, cost enormous amounts of our precious healthcare dollars, and then they die 25 years earlier than the rest of us. It's my life's passion to try and change this. It's not always easy to care for people with such enormous life challenges, nor a system that so often blames them for their poor health. So I try and condition myself by scaling physical mountains from Kilimanjaro to Mount Everest. These treks remind me that all peaks can be conquered, and so can this. But this isn't a story just about the mentally ill. Across all of medicine, caring for the ill begins with a desire to help those who suffer, to treat, to cure, or to prevent the malady that brings discomfort, pain, anxiety, or even the inability to function as before. I submit to you today that we have the way to unlock one of the most profound drivers of successful chronic disease management, namely the influences of traumatic experiences and toxic stress and what you can do about it. The Milbank Memorial Fund study in 2010 found that when symptoms and trauma-related behaviors are left unaddressed, individuals often experience lower productivity, failed relationships, significant distress and dysfunction, difficulty caring for their children, and difficulty caring for themselves in health-promoting ways. So just how pervasive are these experiences that drive such poor outcomes? The truth is, trauma affects almost everyone. Its nature may vary. Natural disasters, as we've seen here in parts of the Midwest and certainly in Nepal most recently. Serious illness, death of a loved one, or at its extremes, physical and sexual violence. There is strong evidence to suggest that many of our seemingly intractable and most costly public health challenges can be traced to the emotional distress rooted in these experiences. The seminal Adverse Childhood Experiences study provides evidence of the profound and negative consequences of trauma on the overall quality of life and clearly demonstrates that traumatic experiences are predictive of poor health outcomes in later life. Let me repeat that for just a minute, if I may. The study clearly demonstrates that traumatic experiences are predictive of poor health outcomes in later life. The study, conducted by Kaiser Permanente and the CDC, focused on a commercially insured population of some 17,000 people in California and actually began as an effort to understand obesity. What they found was remarkably high rates of historical traumatic events directly correlated with chronic health problems. A single woman's statement made the puzzle clear. Having gained 105 pounds in the year after a sexual assault, she said, and I quote, "Overweight is overlooked, and that's the way I need to be," unquote. There are any number of ways that people cope with the emotional distress associated with traumatic experiences. Smoking, alcohol and drug abuse, unsafe sexual behaviors, overeating, and the like. And importantly, they work in the short run. Let's try and put another human face on this story. Rita is a 53-year-old Hispanic woman. Medically, she's pretty ill. Her clinical diagnoses: COPD, hypertension, serious depression, and obesity. But let's go back in time for a moment. When Rita was 17 years old, she was raped on a New York City subway platform. Others were there. No one helped. As we fast forward to today, she now spends her days mostly sleeping in her small apartment and only goes out late at night when there aren't so many people around. What's her experience of herself? She's certainly pretty sad. She blames herself for what happened. She smokes and eats mostly Kraft macaroni and cheese and sweets, all of which make her feel better. Food therapy. How about her medical health? Well, with COPD, she coughs profusely and is often short of breath. When she coughs up blood, she goes to the emergency room. There, they do engage her well. They do lots of tests, lots of patient education, and have suggested on more than one occasion that she come into the hospital. That thought terrifies her, so she always goes to another ER when she has another coughing attack. Well, what's going on here? Does anyone really stop to ask over and over again, why is this individual patient acting this way? She certainly doesn't appear to be confused or seriously mentally ill, just really sick. So what happens to Rita? She's the classic mental health statistic. At 53 years old, she dies. Another tragic statistic proving that people with mental illness die 25 years earlier than the rest of us. So let's you and I think about what's happened here for a minute. A young girl raped, ignored, self-doubt, depression, fear of the medical system, disease progression, and early death. Every day this is happening. It is so easy to steel ourselves against the harsh reality of dealing with patients like Rita. And even though she got a good diagnosis, medical treatment, and follow-up, we see here that empathy and a focus around Rita's trauma were not part of her ongoing care. There is a powerful story being told here, but not just about Rita, but about hundreds and thousands and tens of thousands of people just like her in so many ways. Traumatic experiences are associated with emotional distress and can lead directly to the behaviors that result in chronic health conditions, not necessarily because those behaviors reflect an individual's intention, but rather because they're a means by which people cope with the emotional pain caused by trauma. Here's a diagnostic formulation that leads from Rita's abuse to her early death. As Vincent Felitti said, this diagnostic formulation is so uncomfortable because it underscores that our attention is generally centered on the tertiary consequences far downstream. We also see that social convention, taboo, and stigma prevent us from addressing the core issues. Physicians have too often limited themselves to the most visibly apparent, but in fact smallest part of the problem, to that part with which they are most comfortable as prescribers of medicine. Moving forward with the body of knowledge we have on traumatic experiences and their impact on health, which diagnostic choice would we make? By intervening to address the underlying causes of a person's health-impairing behaviors, there's a much greater likelihood of addressing the person's overarching health as well as the condition of immediate concern. In order to do so, however, medical training will need to become more holistic, taking on the phrase most associated with trauma-informed care. What happened to you? Rather than the more expedient, what's wrong with you? Suddenly, empathy isn't a special nicety. It becomes part of the basic thinking of our treatment approach. Doctors and other practitioners can tell what's wrong with us based on their training and their experience, but they have to ask to know what to really treat. Despite every indication that the health burden of trauma exposure is high, this remains a difficult topic to address for healthcare providers who often do not assess for trauma histories with their patients. Part of the reason is that trauma is a sensitive topic, almost as painful in the hearing as it is in the telling. But we simply must overcome this gap. Early on in my career, one of my jobs was as the children's mental health specialist for a 21-county regional mental health authority in upstate New York. And part of my responsibilities in that job was to go around and visit programs serving troubled kids, most of whom had diagnoses like ADHD, adjustment disorder, conduct disorder, and depression. And I'd go to the outpatient programs and I'd look at the assessments that were there, and you'd often see history of physical and sexual abuse. And I would look at the treatment plans, and there'd be nothing in the treatment plans relating to any of those experiences. And being young, I would go to the clinicians and say, why is that? That's hard for me to understand. And almost uniformly, they'd tell me, well, this is an outpatient program, and in its way, it's unstructured. So to open up a proverbial can of worms that would destabilize the patient, they'd really need to be in a much more intensive, contained environment like inpatient. And my response would be, oh, I understand. Thank you. And some weeks later, I'd be visiting one of the inpatient programs in the area. And again, I'd look at the assessments, and with great degree of frequency, you'd see histories of physical and sexual abuse. And again, I'd look at the treatment plan, and then be nothing referencing any of those experiences, any treatment goals or interventions trying to address the emotional distress associated with that. And again, I'd ask the clinicians, and they'd say, well, this is a very short-term treatment intervention. So we don't want to open up that proverbial can of worms and then have to discharge the patient before they were able to complete their treatment. So these young patients, frankly, were left on their own to figure out how to cope with the emotional distress of massively unpleasant and traumatic experiences. Our deepening understanding of trauma and its consequences demands that providers not only understand the links between traumatic experiences and health outcomes, but also begin to work collaboratively with their patients to address the individual's whole health needs. There's another pathway that Rita's story might take. The doctors in the ER where Rita presents asks her about any troubling things that may have happened in her past. She nods and says, no one ever asked before. The medical team begins to see Rita's bad habits as compensatory behaviors. The trauma-trained peer health coach offers to walk her home afterwards to ensure that she gets there safely. They begin to talk about how her poor diet choices or compensatory behaviors had helped her feel safe for so long, but that in fact now were hurting her. The next day, the health coach calls again and see if Rita wants to go shopping. She declines, and this is repeated for 3 days. On the 4th day, the health coach goes shopping for Hispanic food that Rita's mentioned during one of their phone calls. Rita's thrilled. They go for a walk that afternoon, the first time she's been out in the daylight in years. Suddenly, Rita begins to feel a little more safe in public. The health coach starts a discussion with her on other ways that she can feel safe and be healthier. Her long-forgotten ethnic pride is rekindled, and she begins cooking classes. She walks to class. Her eating habits begin to change. She begins to develop a small network of friends with whom she feels safe. Her blood pressure and her weight begin to go down, and she takes the health coach's advice to stop into an integrated care clinic and begin treatment for her COPD and her depression. This better pathway that I've just described for Rita is overly simplistic. Few cases are this straightforward, it's true. But it's also very real and very possible. And in fact, we at ICL see it every day. I believe that the effects of traumatic experiences and toxic stress are one of the best documented, yet most unrecognized and underappreciated drivers of poor health outcomes, of health disparities in distressed communities, of unnecessary spending, and of human suffering. Yet little of this, in my opinion, has made its way into medical education, practice, or social policy. But it's not just pie in the sky thinking either. We at ICL have developed a treatment approach that we refer to as TRIP. Trauma-informed at the top of the list. Recovery-oriented, integrated health and behavioral health, person-centered, culturally competent. What we have been able to accomplish with our seriously mentally ill clients in inner city, highly distressed neighborhoods in New York City is, in my opinion, remarkable. In the last year alone, we were able to reduce hospitalizations for mental health reasons by 48%, and perhaps more significantly, by 42% for physical health reasons. Our actual medical interventions are fairly modest and mostly routine. What we are able to do is get people to trust us and then help them to take better care of themselves, just like Rita. While the chart on the screen relates to the successes that people with serious mental illness achieved, of perhaps equal or maybe even greater weight in my mind are the implications of this paradigm across the healthcare universe. In the same way that we have ignored the emotional response to trauma in the healthcare provided to the most seriously mentally ill, I believe we often do the same thing across a continuum of emotional distress. Numerous studies support the fact that as many as 70% of all visits to primary care stem from psychosocial issues, with patients typically presenting with a physical health complaint. 70%. The data suggests that it is underlying mental health or substance abuse issues that are triggering these visits. A diabetic woman who was exposed to domestic violence and alcohol abuse as a child constantly eats cakes and sweets to control her anxiety. Her doctors are frustrated because they've explained the negative health consequences of her behavior to her innumerable times without success. They can't understand why she doesn't change her behavior in light of such evidence. But we can. A 55-year-old man who lives in the suburbs He's had a heart attack some 6 months ago. His cardiologist assures him he's fine now. He's terrified. He's stopped playing golf, stopped being intimate with his wife, and has called an ambulance the last 3 times he's tried to mow the grass. These people show us, as does the ACEs study, that these kinds of life experiences are pervasive, yet their power in our lives remains strong. We all, in our own ways, try to find ways to feel better. For many, without regard to the future consequences of those compensatory behaviors. Integrated care is the buzzword du jour. It mostly means shared information or occasionally physical co-location. Neither has been easy, and the outcomes to date are, in truth, fairly modest. The next generation of integrated care will be one that incorporates the critical role that emotional distress plays in our lives and in our health. From the most serious forms of trauma to our sometimes obsessive worrying, it all matters. We don't as yet have a healthcare system that's responsive to all of this, but I believe we will. The evidence is too clear, overwhelming in fact, and the outcomes too critical. The Cleveland Clinic has brought us here together to explore a sensitive topic, empathy. It's not a discussion about offering hugs or of the importance of good listening. It's about saving lives. We, you and I, have the potential to break the legacy of trauma's impact across the spectrum of healthcare by understanding how current behaviors are linked to past personal experiences, honoring the important role that they may have played, and helping people find new, more health-promoting compensatory mechanisms. We can improve people's lives. The results will be patients who are more engaged in their care and providers who are more able to fully integrate that care and more meaningfully impact their patients' lives. A mountain that we all can climb. It has been an honor to speak with you today, and I have been genuinely inspired to be with so many people committed to improving the lives of others. I thank you. I welcome your thoughts and reactions. I think looking at this giant ticking clock that's down here, we do have a few minutes. I'd be happy to entertain anybody's thoughts or reactions or questions that I may answer if that's what you'd like to hear. There are microphones here and over there if anybody has any questions or comments.
Thank you so much. That was very inspiring.
Thank you.
So, of course, we all want to leave here and do better. And my question has to do with patients coming through the emergency department and not having resources like a health coach or a 24/7 case manager. And if I coach my staff and my physicians to ask the important question, and what happened to you? How will I be able to make that better for the patient? How will that affect my care for the patient if I do not have those resources?
It's a great question. Thank you. A couple of quick thoughts on that. One of which is there are so many initiatives across the country going on right now that are beginning to shape the value-based purchasing paradigm. I think all of this is a real challenge, particularly for the healthcare end of the continuum, to accomplish in a high-volume fee-for-service environment. But I do think the emerging value-based purchasing paradigms really lend itself wonderfully to this whole idea. Rita, who's really a composite, by the way, I don't really know that person, although I feel like I do. She goes to the ER all the time. If we can begin to make the case exactly like Rita's to the payer community, if we can prevent a half a dozen ER visits for exactly the same repetitive reasons because Rita hasn't changed her compensatory behaviors, that's how you could begin to engage payers in thinking differently about the fee-for-service environment. And that's some of what we've been able to do, is begin to work with not only our own providers, while we're predominantly a mental health type agency, we've got primary care docs in our licensed mental health program, so they can begin to have those discussions. But I think the emergency rooms of the future will really be the place where people are feeling their worst in some ways and begin to appreciate that they don't have to feel that lousy all the time without, and I think this is a key, we're just having a conversation with somebody earlier today, it's not just about like changing your diet, because just like diets don't often work for people in general, if we're not addressing the reason why people, in Rita's case, are eating Kraft macaroni and cheese all the time and not getting any exercise, the obvious superficial answer is quit eating all that stuff and take a walk once in a while. If she's not going to do that because that's not what makes her feel well, she's going to fall right back into that. So I think if we can begin to look at not just the whole health needs of a person, but the expenses related to their utilization patterns, you can begin to say we can bend this cost curve in ways that will help everybody, payer and patient and practitioner alike. Yes, ma'am.
Hi, yes, just an observation I made. I'm from Connecticut, and we had a situation in Newtown where there was a shooting, and I was very excited to hear over the radio stations that they had said at one of the state armories they were going to have kind of like a CPR, or like a first responder, as opposed to physically somebody having a heart attack. It would be like let's get the community ready to do a mental health first responder type of so the civilians, and they said, oh, they'll be going from this one, they'll go to that one, and then everything just fell by the wayside, and I never heard anything more about that. So, the intentions are good, but where was the follow-up? And I'm just so happy to be here to see that, let it begin with us.
Yes.
So,
yeah.
Thank you.
Yeah, thank you. I mean, this is all really, for me, is a bit of a soapbox, because I think there remains so much stigma and so much taboo around mental health issues. And, you could easily see in that little vignette of that suburban gentleman who obviously has massive anxiety, his cardiologist, who says he's just fine, saying, well, you're acting really strangely. There's nothing wrong with you. Why don't you see a psychiatrist or something? And in one of the earlier iterations of that talk, I said, I quoted that individual as saying, I'll be damned if I'm going to see a psychiatrist. I'm not nuts. And he's not nuts. And he's not mentally ill. So I think, almost to your point, if we can begin to appreciate the emotional dimensions of healthcare, not as being something defined as at its worst, a character flaw, and maybe at its best, a mental illness, and begin to appreciate and honor the role that the emotional dimensions of our lives play in our day-to-day functioning and in our health, we can begin to change that sort of thing so that the stigma associated with that, and people, once the crisis is over, not wanting to acknowledge that they may have started using all kinds of compensatory ways to manage that the pain, which I can't imagine the families of those kids in Newtown. How are they managing those things? And even in whether it's in the ER, in a more generalized environment, or in the Newtown thing, begin some quick discussions around what kinds of helpful compensatory behaviors can we help you think about to manage this, rather than reaching for some alcohol too quickly or any other of a series of ways that people, all of us, frankly, we were laughing as we went to dinner last night, and there was a large crowd at the hotel bar, and I said, there is a whole lot of compensatory behavior going on, and then we joined because I had to give a speech the next day, so. Well, I'm about out of time. I appreciate everybody's attention. I really hope you try and take this to heart and do what you can to help understand people's traumatic experiences. Thank you much.